why when I take a history from a patient, I will always ask, around what age does your mom remember
Right,
that you went through menopause, and
right.
then that way they can kind of gauge a little bit as to around when they might be starting to go through perimenopause, because I know that data, and based on their ethnicity, I know that if they're Caucasian, it's going to be around 7 years that they'll be in perimenopause. African Americans, about 10 years.
Are you a busy woman who prioritizes everyone else's health above your own? Do you have questions about your diet, exercise, or how to prevent or treat certain health conditions? Are you always Googling health questions that you forget to ask or are embarrassed to ask your primary care physician? Girl, do you even have a primary care physician? Well, welcome to Headed to Healthier. I'm Dr. Brittany Anderson, a board certified family medicine physician, and every day in my private practice, I have discussions with women just like you who are doing their best to juggle the demands of life while also desiring to become healthier. Inside this podcast, you'll find practical and actionable health tips that you can incorporate into your daily life. You'll get expert advice and insight from some of my awesome healthcare colleagues, and you'll hear relatable conversations with incredible women just like you who have made their health a priority and are thriving because of it. So throw on your sneakers and get some steps in while you listen. Or if you're driving, get those hands at 10 and 2 and let's dig in. We are headed to healthier. Hello, ladies. Welcome back to today's episode. I'm so excited to be joined by Dr. Lodhi here today. Dr. Lodhi is a obstetrician gynecologist, practicing mostly gynecology now. Is that right, Dr. Lodhi?
Yep, yep, yep,
And
yes.
based in New York. And so even before this call, we've spent a lot of time just talking about Alabama versus New York and the differences in our practices. So as you all know, I am family medicine doc, and Dr. Lodhi, like I mentioned, is a gynecologist. We want to get into today a little bit about women's sexual health. We want to talk about perimenopause, menopause, decreased libido, decreased sexual desire, hormonal shifts, all the things. I know that so many women have these questions. And so, Dr. Lodhi, welcome to the show. I'm honored to have you here today. Would you mind just introducing yourself?
Yeah, of course. And thank you so much, Dr. Anderson, for giving me the time and allowing me to come onto your podcast. So my name is Dr. Sadaf Lodhi. I am a board certified OBGYN. I have been practicing now for, gosh, let's see, 21 years. I've been doing obstetrics and gynecology. I still do obstetrics a little bit. I'm a
Great,
locums physician where I do deliver some babies in the
great.
Bronx in New York. And then I have a private practice closer to where I live. And I deal with my outpatient gynecology, but my niche is perimenopause, menopause, and sexual health. And I'm also a sex coach. I'm also a Menopause Society certified practitioner, as well as an ISHWSH fellow. ISHWSH stands for the International Society for the Study of Women's Sexual Health. And yeah, so I focus on all things that we never talk about, that are all taboo and people whisper about, but don't actually mention
Right.
they're struggling with it.
Right. And you're so right that sometimes amongst circles of women, it's not something that comes up, but it does come up occasionally in the office. And I say occasionally,
Yes.
it actually comes up pretty commonly in the office. And so, I'll have a patient come in and we're talking about some of kind of their chronic health needs and maybe acute issues or things that are going on right then. But then they bring up, perimenopause. Dr. Anderson, do you think I'm at perimenopause? I'm noticing these changes in my body. What do you think these are about? And I love to be able to stop and talk with patients about these things, but I know that you have so much more experience in this area than I do. And so I would love to kind of pick your brain a little bit, just as how you approach this with your patients. We were talking a little bit about the difference in the amount of time that we're able to spend with patients. So, but one difference in my practice and yours is that you are a direct specialty care office. And so you get to spend a lot more time with your patients having these discussions than I do. Would you tell me just what a normal kind of office visit looks like in your office and how much time you're able to spend with your patients?
Yeah, yeah. So, as you and I were talking a little bit offline before, so I spend my first visit with me is about an hour and a half to almost 2 hours long.
That blows my mind, Dr. Lodi.
I know. I saw your eyes widen when I told you that. The reason why it takes so long is because I do a lot of teaching, I do a lot of educating, and it includes like a full exam. So I'm doing, like the breast exam, the pap smear if they need one, doing referrals, writing out prescriptions, all of that stuff is all included in the first visit. And then a follow-up visit is anywhere between like, can go from a half hour to 45 minutes to even upwards of an hour as a follow-up. And that's because, a lot of times people have questions and or they just started a new medication and they're not sure if they're doing it right. So then we go, we do some more education around that. We talk about their symptoms, whether or not they're getting better, do they need more medication or what? So, it's a lot of, there's almost like an art to this menopause, perimenopausal care because you really want to get it to the ideal dose of medication where the patient is starting to feel better, they're feeling more like themselves, they're not having as much brain fog and joint pain and all of that stuff. So we'll definitely get into the symptoms because I know that that was something that you were wondering about.
Yeah, absolutely. My patients would be in awe if I stayed in a room for more than 45 minutes to an hour. They would probably tell me to get up and leave, although I could probably do it. My nurses would be the ones who would come tap on the door and tell me that I have to move on to the next patient. But I know that your patients really appreciate that. And like you said, when we're talking about perimenopause, menopause, and sexual health, that is something that takes a lot more. It takes finesse, right? It takes finesse, it takes time to be able to sit down and really get into those conversations with patients. And so I applaud you for what you do. I've already told you whenever you are ready to set up a practice in Alabama, I'm sure that I and local colleagues can certainly keep you stocked with patients. What a wonderful concept for a practice that you have. So you mentioned symptoms, and if we can just jump right into it, let's start with perimenopause. And
Yeah.
again, as much as this is a time for my audience to learn, I'm learning here too with them. And so let's talk a little bit about perimenopause and kind of what that looks like when a patient comes into the office, what type of symptoms you commonly see in your patients, and just in general, how do women even know if they truly are at a place of perimenopause?
Yeah, those are, such amazing and fantastic questions. I love it. So, okay, so if we think about it, we know that the mean age for somebody to go through menopause. So, for your audience, for anyone that may not know what menopause is when you go a whole year without a period. That's menopause. So, and then all the time thereafter is called postmenopause. The time before that time is called perimenopause, right? So, that just in terms of definitions of what we're talking about. So when we get into how do we know when we're in perimenopause? So let's think about when somebody goes through menopause. They say it's between the ages like around 51, 52, but really that depends on your genetics. It also depends on your ethnicity, is what we're learning. There is a study that was done, started in 1994. It's called the SWAN study. And basically, it stands for, it's an acronym, it stands for the study of women's health across the nation. And it is a multi-center study that looked at women as they went through midlife, and it's still ongoing. You can actually Google that, you can look up that study, and it will tell you about the changes that happen in midlife, the psychological changes and what type of symptoms a patient experiences and things like that as they go through perimenopause and then into menopause. So when we talk about perimenopause, we know that based on this study, we learned from this study rather that different ethnicities go through perimenopause for different lengths of time. Okay. And that was one of the most, I would say, like landmark breakthroughs that we learned from the SWAN study. And we learned that Asian women, so we're thinking about like Chinese and Japanese women, tend to go through perimenopause about 5 years. We know that Caucasian women go through, based again off of this study, go through perimenopause for 7 years. Hispanic women, 8.9 years, and African American women for about 10 years. So if you think about menopause, the mean age for somebody going through menopause of being 51, 52. Now remember, some people can go through it later, some people earlier, but that's generally around the age that somebody will experience menopause. 10 years, if you're African American, 10 years prior to that, that would be starting around the age of 41. And let's say in your family, based on your ethnicity and in fact, we don't really know. So I'm Southeast Asian. We don't have that much data on Southeast Asians, but when I was going through my research on that, I learned that Southeast Asians can go through menopause around the age of 48, 49, and about in terms of the lengths of perimenopause for them, it varies. So some studies say like 7 years, some people say 10 years, so anywhere around that. So if we're thinking, we can even say that for some women, perimenopause may even begin in their late 30s, right? So around like
Mm-hmm.
38, 39,
Mm-hmm.
and depending. So that's why when I take a history from a patient, I will always ask, around what age does your mom remember
Right.
that you went through menopause, and
Right.
then that way they can kind of gauge a little bit as to around when they might be starting to go through perimenopause, because I know that data, and based on their ethnicity, I know that if they're Caucasian, it's going to be around 7 years that they'll be in perimenopause. African Americans, about 10 years. The reason why they think perhaps when you dive down, dive a little bit deeper into why they think that African Americans tend to go through perimenopause for 10 years, the thought is that perhaps of systemic racism and because of something called weathering. Weathering is where basically you have your genetics changes due
Right.
to systemic racism, and it's also epigenetics, so where your telomeres on your DNA will actually shorten. And they think that that could be possibly one of the reasons why African Americans tend to go through perimenopause for so long. So we have to really just understand who it is that we're talking to, and
Mm-hmm.
understand a little bit about their background, their culture, and what they might be going through. And that's why I think it's so difficult when they may go in their 40s and be telling their doctor, hey, I'm having these irregular menses, or I'm having this brain fog, or they may not even know the term for brain fog, right? Like, I didn't
Mm-hmm.
know the term for brain fog until like a few years ago, right? I just knew that there were times when I would be
Right.
talking and I would forget what I was saying, or I'd go into a room and I'd be like, gosh, why did I come in here? I don't even remember why I came in here, and then it would take me a little while before I remembered again. So all of those things,
Mhm.
right? It's all about education and empowerment, but it's about teaching individuals what's going on and then giving it a name, right? Because once we have a
Right.
name
Right.
of something that
Absolutely.
we're experiencing, then we're able to relay that information to our doctor.
Absolutely. And I think that's why discussions like this are so important. You and I both are aware of shifts that are kind of going on within medicine to encourage more physicians to become more aware of perimenopause and what those symptoms look like and true menopause so that we're not dismissive of patients when they come in. And so even if they are coming in the midst of multiple other, chronic conditions or acute things to talk about, that we really need to take these symptoms at face value and start to address them. And so, can we talk a little bit about symptoms then? Like you mentioned earlier,
Yeah.
so you mentioned the brain fog, which is a big one. And you're so right that sometimes it's hard to put a name to that. The description that you gave is great. And sometimes that's what I get from patients. I get that description of being in the middle of saying something, then losing my words, or having to take a little bit longer to think through things. We certainly hear that from patients. What other kinds of symptoms do you commonly hear patients talk about around the time of perimenopause?
Absolutely. So there's definitely, we have a lot of women that come in and will talk about their periods starting to become either, longer, heavier, or there's a bigger time frame in between periods, right? From the start of one period to the start of the next period, women may start skipping months. And so then as that time starts to get longer and longer between one period to the next period, that's when we definitely know that, they're starting to be in perimenopause. But then remember, you can also get that confused with like PCOS when you're thinking
Absolutely.
about like, oh gosh, is she in perimenopause? Is she in PCOS? One of the key things though that I would say helps to make that distinction is, are you having hot flashes or night sweats, right? We
Mm-hmm.
know that those vasomotor symptoms, those hot flashes and night sweats are, almost pathognomonic, right? Like definitely something that indicates to us that this individual is getting, is in perimenopause, maybe closer to menopause. And those are one of the, key symptoms that a lot of women will start to have. I just actually was at a dinner party last night, and this woman who's in her mid 40s told me that she wasn't having hot flashes, but she was having night sweats where she was, waking up all wet at night. And she was like, oh, I thought that that was just due to the fact that I'm a little bit overweight. And I was like, no, you're in perimenopause, and you're starting to have these thermal regulations, right? Like the temperature setting basically in our brain is a little bit off, and that's due to this kind of roller coaster picture of estrogen that we have in perimenopause, where you have some very high highs and some low lows, and that change, that delta between the high and the low, is what's giving you all of these symptoms. And she also, a lot of the women in that same dinner party that I was at were talking about unexplained rage, right? Like they're
Ah,
getting this
yes,
emotional
absolutely.
emotional lability where, sometimes they're so upset at their husbands and they don't know why.
Mhm.
And they're just getting, and they're like, and it's so funny listening to these women because they're like, I'm so happy when he goes away on trips because I don't have to deal with him. And just him being near me makes me so angry.
Sometimes in my practice, the husband comes in with the wife, and it's like, you have got to do something here, Dr. Anderson. We have a
Yes,
problem. Either she's freezing me out of the house or she's
yes.
snapping at me all the time.
Yes, exactly, exactly. And then you have, fatigue and pain with sex and vaginal dryness and decreased libido. But it's so funny that you mentioned that these women will come in with their husbands, because the same dinner party, these women were talking about how I need to do a webinar for men, for their
Yes.
partners,
Oh,
right?
you
And so
should.
and just talking about what happens, she's one of the patients, she's one of the ladies there. But anyways, but she was like, I just want you to tell my husband that,
Hmm.
it's not me, but it's my hormones that are going all
Right.
crazy, that I'm becoming like this. And she goes, my husband's telling me, oh, you're overthinking, you're this, not in a bad way, but he's just trying to figure out why she's changed so much. And she's like, I don't know why I'm changing, I don't know what's going on. And so much of it has to do with education, right? But it's also
Absolutely.
not just, and it's so funny because in gynecology, I'm so focused on the woman that I
Yep.
forget that
Yep.
typically they're a dyad, right?
Right. Absolutely.
That's being affected by the perimenopause and menopause. And when you help the patient that's sitting in front of you, you are actually helping that couple, come together more. And I think
Absolutely. I've had husbands call me back, ask my front staff to speak with me and tell me thank you for treating their wife.
oh,
And so that
amazing.
is, you're absolutely right.
Yeah,
It is real.
yeah, yeah. So there's a lot of chaos
Yes,
that happens in
absolutely. I
perimenopause.
bet you are a hit at dinner parties too. I bet you get all the questions.
Well, it's funny. I try not to like
I
take over
know, I
a
bet.
conversation, but
Yeah,
like we're all women of a certain age and they're all
right. It
talking,
happens.
and I just sit there and I try to be quiet for as long as I can. Then all
I
of a sudden
feel
I'm like,
you.
oh, okay, I can't. Like I gotta start talking about this because they're like saying like all this crazy stuff.
Exactly.
And sometimes women will be like, oh, but I heard hormones are bad and it causes breast cancer and it does this and it does this. And I'm like, no, 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 no. I'm like, let's stop. Let's stop. I'm like,
Hmm.
they're
Hmm.
not bad. I'm like, it's gonna help you anyway. So yeah.
Absolutely. And there's so much misinformation that's out there. I wanted to
Yeah.
get to this later, but I'm going to pause right here to do this now. I
Yeah.
know that you have a podcast
I
and you have a TikTok, you have social media where you are actually out here speaking truth and speaking actual medical facts. And so I'll plug it into the show notes, but could you right here in the middle of this recording go ahead and let my listeners know where they can find you on social media, online, etc.
Oh, you're so sweet. Thank you. I appreciate that. So, yeah, so I'm on TikTok and Instagram at Dr. Sadaf, OBGYN. So it's, the at symbol, DRSADAF, OBGYN. And then my podcast is called the Muslim Sex Podcast. Now, I get this question all the time. It's not just for Muslims, it's just a name. It's kind of a name that, stops people in their tracks. They're like, what the
Yeah,
heck is that? Right? Like,
yeah,
you never hear Muslim and sex in the same sentence
right.
ever. So that was kind of the reason why we did that. And it's been I'm in my fourth season now, and I have great practitioners, physicians that come on, sex therapists come on. We talk about sex, we talk about libido, we talk about orgasm, we talk about perimenopause, menopause. I do a whole menopause 101 lecture on there. Just last Friday, I talked about lichen sclerosis.
Mhm.
I talk about pain with sex. I talked about the new guidelines that came out about the gender urinary syndrome of menopause.
Mhm.
I talked about with a sex therapist, I talked about kink 101. So there's so many different topics. I had somebody come on that was an attorney that talked about domestic violence. We talked about anxiety in relationships. We talked to psychiatrists. So we just, run through the full scope of topics. Um, when it comes to sexual health, when it comes to perimenopause, menopause, I'm a sex coach. So I talk about like mindset and how to, experience more pleasure in your relationship. We talked about different modalities like sensate focus and increasing mindfulness in your relationship to increase libido. I have fantastic people that have actually done research and have written books on the topic. So really great information,
It
and it's
really is.
global, and I've always wanted to make a difference in the world, and I think this is the way to do it. And last year I received alumni of the year for my alma mater,
Oh, congratulations.
yeah, for the from the University of Michigan, Dearborn, and it was for my podcast for
Oh,
helping
that's wonderful.
erase taboo and stigma
Mhm.
around these very important topics.
Well, that sounds fantastic. I really applaud the work that you are doing. I'm going to tag all of your socials in the show notes here. And ladies, I'm going to try my best in the future to get into more episodes related to sex health, but I probably will be pointing you back to Dr. Lodi. She is the expert here. And so absolutely go check her out. You mentioned earlier when we were talking about perimenopausal symptoms, and I wanted us to get into a little bit about the shifts that a woman goes through. And so, whether that is physical shifts, so the increased weight gain, whether it's decreased sexual desire or libido, can you talk about what the underlying factors are that contribute to this and how we even begin to address it?
Yeah, such a fantastic question. So, the underlying issue, of course, is with hormones, right? So we know that as we're going through perimenopause and into menopause, we know that our hormones are starting to decline, specifically estrogen, progesterone, and testosterone. Estrogen is the one that kind of fluctuates, not kind of, but fluctuates the most.
Right.
And that's what causes all of like the turmoil that we feel with the emotions, the new
Hmm.
onset anxiety and depression, and the decrease in libido is due to the estrogen starting to go down, and that causes some pain with sex, but also with the testosterone that starts to go down as well. The problems with our sleep happen because as a result of the progesterone starting to go down. So all of these hormones, estrogen, testosterone, progesterone, all play a key factor in in all of the things and symptoms that we're feeling in perimenopause, and of course, as we go into menopause. A lot of women tend to notice weight gain, like you mentioned. So we see a redistribution of fat due to the decline in estrogen. Fat in our reproductive years tends to be around our hips and our thighs. And as we go into menopause, it tends to redistribute around our waist. And that's why a lot of women will notice that we start to gain weight. Also, we start to see an increase in visceral fat. Visceral fat is the fat that surrounds our organs, it's the bad fat. And so
Yes.
those that fat can also lead to an increase in insulin resistance. And so when that happens, we see women in perimenopause develop pre-diabetes. And I'll actually tell you a quick story. So one of the years that I went for my annual exam, I was getting my blood work done. I had it done and it came back as pre-diabetic, and I like completely freaked out. I was like, what the
Oh,
heck? No way. This can't be happening. But it could have been because I was having like these Lindt
yeah.
chocolates after breakfast,
Oh,
lunch,
they are
dinner
so good. Oh my gosh,
for,
I'm obsessed.
for like the past 3 months. So that could have been it. But anyways, I shut that down real quick and I repeated it and it was fine. But it's at that time, I didn't know as much as I do now about being in
Hmm.
perimenopause. And,
Hmm.
I think that had I known a little bit more, I would have realized that that's what was happening, is
Right.
that we start to see these changes, right? These cardiometabolic changes as we start to go from perimenopause into menopause. So women that never had diabetes can become pre-diabetic. We see also with this decline in estrogen, our arteries start to get affected as well, because remember, estrogen is anti-inflammatory.
Hmm.
And so
Hmm.
we know that as we start to lose this estrogen, right, our arteries can start to stiffen up a little bit, and then that can lead to high, blood pressure going up. We know that a cholesterol also starts to increase in perimenopause, menopause. All of these changes happen as a result of this estrogen going down. And so it is really, really important to stay up to date with your physical exams, also to stay
Right.
up to date with seeing your doctor every year to get this blood work to make sure that you know what's happening. And if you're having these symptoms of, becoming all of a sudden pre-diabetic, right? This is so actually I wrote this paper and I'm looking to get it published. So I'm still looking for an avenue to
Awesome.
figure out where to get it published. But I say that perimenopause is a window into your future. And the reason why I say that is because these things start to develop, right? Like the slight increase in blood pressure, this increase in cholesterol, this pre-diabetes, all this stuff starts to happen in this perimenopausal period. And that is our time to make changes, because
Mhm.
if we don't, we can develop this diabetes, we can develop this high blood pressure, we can develop this high cholesterol. And I will tell you, I will say about like 50% of my patients that are in menopause all have high blood pressure, all have diabetes, right? So these things happen. And so perimenopause is this time. And the reason why I call it the window into our future is because in OBGYN, we say that actually pregnancy is a window
Mhm.
into the future of a woman, because we know that a woman, if she develops diabetes in pregnancy, has a 50% chance of developing diabetes later on in life. If she develops high blood pressure or preeclampsia in pregnancy, there's this. I think it's like, I have to look up the statistic, but it's like 3 to 4 times more likely that she's going to develop hypertension later on in life. So we tell somebody that develops diabetes and high blood pressure in pregnancy to really be careful, and
Right.
to really assess their health once they are postpartum, because these conditions are real and they can manifest as chronic diseases later on in their life. And it's really this opportune time that pregnancy kind of showed them their future, but they have the ability to change their future. And so, we're seeing now more and more people are deciding to go childless by choice. And so if that's the case, then we don't have that pregnancy time frame anymore to take a look
Right.
into their future to
Exactly.
see what conditions they develop. But if we use perimenopause as a time to look into a woman's future, then we can hopefully help her to not develop these chronic diseases that she's at risk for developing.
Absolutely. I think that's so powerful. And one of the things that I certainly see in my own practice is that, women who you mentioned before who had no issues with diabetes, pre-diabetes leading into it, but here we are at 45, 46, 47 with these new diagnoses.
Yeah, absolutely, absolutely, definitely that happens. And I'll talk also a little bit about desire. We noticed that a lot of women suffer. So there was this study that was done. It was called the Preside study, and it was actually like a questionnaire. I believe it was like with 38,000 women. And if you're part of Ishwish, it's part of like their slide deck. They have like 500 and some slides on sexual health. This one of the slides that talks about the study, the Preside study. And what this study, or really this questionnaire that they sent out to all these women in the United States, and what they asked them is, are you experiencing any type of sexual dysfunction, right? And
Mhm.
when they received that questionnaire back, they noted that most women that had any type of sexual dysfunction typically had it in midlife. Midlife was defined as the age between like 40 to 65. When they looked at what type of sexual dysfunction, it was with desire, it was orgasm, it was with, I believe it was with pain. And what they noted is that the biggest sexual dysfunction that caused distress. So about 44% of women experienced sexual dysfunction, about 12% of them experienced it with distress. What they found out was, I believe it was 38% of women experienced low desire, and of that percentage, about 10% experienced it with distress. So we know there's a condition called hypoactive sexual desire disorder, which is women that experience low desire with distress. Now, remember, if it's not associated with distress, it doesn't really matter because it's not bothersome to you. But when it's associated with distress, then it's bothersome, then it's a problem. And that's when that hyperactive sexual desire disorder or diagnosis comes into play. And what's important to note is that this tends to show up in midlife, right? And why is that happening in midlife? Well, when we again take a look, what's happening in midlife where women are experiencing perimenopause, they're going into menopause, these hormones are kind of the estrogen is all kind of crazy, it looks like a roller coaster. But we know that progesterone slowly starts to go down, as well as testosterone slowly starts to go down. We know that testosterone is responsible for libido. We also know that if somebody's experiencing pain with sex, they're not going to want it, right? So that's definitely going to affect their libido. What causes pain with sex? Well, if you have decreased lubrication, decreased arousal, if you're not experiencing pleasure with sex, again, you're not going to want it. And so, all of those things, both the estrogen and the testosterone decline will affect your desire, will affect the arousal, will affect lubrication, and all of those things will affect your, want to be in a perhaps sexually active with somebody, right? But also remember, sleep disruption happens at this time as well. And if you have sleep disruption where somebody's experiencing hot flashes and night sweats, it's going to affect their energy, their focus, their mood. And when somebody is exhausted, and I'm speaking from personal experience, being post call after doing a night shift on labor and delivery, I am telling you, you are, I don't want to say it, but the not so nice person post call when you are exhausted,
Absolutely.
right? So, when you're not, you're exhausted, you're tired, and, so we know in midlife that sleep is affected. In fact, the New York Times just had an article, I believe it was last week or the week before, talking about perimenopause is ruining my sleep. And, they go into talking about, what all the things that you can do with sleep disturbances in perimenopause. But, one of them being, of course, hormones. But if you decide you don't want to do hormones, they suggest, also being tested by a sleep doctor to make sure you don't have sleep apnea that's affecting your sleep, but also maybe even trying hypnosis or cognitive behavioral therapy or things like that. But it's just really important to know all the things that can affect your libido and your desire to even want to have sex, right? We talked about estrogen and testosterone decline. We talked about sleep disruption. We talked about painful sex, right? Which happens as a result of this decline in estrogen. And what happens is that you have decreased blood flow to the vulvar region. When you have decreased blood flow, you're going to have decreased lubrication. You're going to have decreased sensitivity. It's going to make pain, it's going to make sex uncomfortable. And anytime somebody, experiences pain with anything, you're really not going to want it. And so that's lead to, again, decrease in libido or decrease with intimacy. There's also stress that develops, resentment, relationship dynamics that change due to whatever's happening. You and I talked a little bit offline about how, a lot of the women we're talking about, and also on this podcast, how we talked about, the relationships with the women and their husbands and how their diets and how their relationships are changing. And
Mhm.
if their relationships are changing and she's always snapping and angry at her husband, he's probably not going to appreciate that. And that's probably going to cause some relationship dynamic issues. And then, whatever, and I always say this is whatever's happening outside of the bedroom is also happening inside of the bedroom. So if you're not
Mhm.
talking outside of the bedroom, you're probably not talking inside of the bedroom. And you're probably not going to want to have sex with somebody that you're always angry at, right? That also happens. And then we talked about waking, right? So the body image shifts. If we're not seeing ourselves as sexual creatures anymore, we're seeing ourselves as like fat and, oh, I don't look good anymore. And look at me. I used to be so good looking when I was 20 and now, I'm just frumpy and this, right? So all of these things are definitely going to affect how you see yourself and how you feel in terms of a sexual relationship and how your libido is.
But how do you even start to approach that with patients then?
So what I always do is I will always ask the patients if they are sexually active, right? So that's how I start. So when I get a full history on the patient, I'll ask them about, their medical, their surgical, blah, blah, all their history. And then I'll ask them about their sexual history. And I'll ask them, are you sexually active? And if they say no, I say, okay, would you like to be sexually active? Or were you sexually active in the past and things have changed? Is it something that you want? Because if it's not something that you want, then it's not a problem and we can just move on. But if it's something that you were sexually active in the past and you're not now, and it's because of, X, Y, and Z, then would you like some help with that? Is there something that you would like to talk about? Would you like to discuss it? So I try to keep it open-ended so that patients feel comfortable discussing and I express to them that this is a safe space that they can talk about whatever it is. And some of my patients be like, oh, this is TMI. I'm like, it's not TMI for a gynecologist or a
That's why
sex
you're
coach or a sex med doc, right? Like
right.
anything goes. Like it's not, I appreciate when patients tell me because then I know what issues they're having and how I can help them.
We've talked about this transition and how it is very commonly a taboo topic. What do you wish women knew going into this transition point of their lives? You've already talked about the importance of being able to describe your symptoms and to be able to be open with your physician when you're talking to them about it. But how do you feel like women could better advocate for ourselves during this time?
Yeah, so that's, I love all your questions. So, I think that one of the key things and myths that I would say that is often, talked about in different cultures, perhaps, is that you just have to write it out, right?
Yeah.
Like it's just one of those transitions that you just deal with. And then, I'll hear some women, at parties and things like that, and they'll say, "Oh, I went through menopause, X amount of years ago, and now I'm on the other side." And I'm like, what does that
Right.
even
There's no
mean?"
badge of honor. You don't get a badge of honor at the end of it.
Right? I'm like, what does that even mean? Like, what does it mean you're on the other side? I don't know. What is the other side, right?
The
But
other side.
but what I wish women knew is that, it's menopause and perimenopause, right, is not a personal failure. It's a biological shift. It impacts your brain, your bones, your heart, your mood, and it's not just about your periods, right? And you don't have to write it out. You can also, I wish that women knew that they could get help for their hot flashes, their night sweats, their sleep issues, their painful sacs, that you don't have to deal with all of this, right? That menopausal hormonal therapy is safe and effective, and that honestly, most women can take menopausal hormonal therapy. We have different ways to take it. There are pills, there are gels, there are sprays, there's ring. I mean, there's patches. There's so many different ways to take menopausal hormonal therapy that, definitely not one size fits all. And you just have to go to somebody that knows how to use it and that can work with you to find something that, will treat your symptoms and it works for your life. Also that, these symptoms are not just stress, they're physiologic and they're real, and really important to just advocate for yourself. If you notice symptoms like, I'm noticing more and more that I'm having pain with sex, or that I'm not able to get lubricated when I'm trying to have intercourse with my partner, or that, I don't feel the orgasms as I once used to, or that, my mood is off, my anxiety is so worse, I'm having these panic attacks, I'm having depression. I never had depression, but all of a sudden now I feel like I'm having depression. I'm gaining weight, my joints ache, I'm having heart palpitations, I can't remember when I'm talking. All of these things, right? If you start to write them down, really could probably fill a book, right?
Right.
Because
Absolutely.
all of these symptoms that women experience that they just think that they're just supposed to deal with, that they don't really know. And like you said, it's not, you don't get an award at the end
Right.
of this,
Yeah.
right? Like,
Yeah.
when we leave this earth, nobody's going to be like, oh, amazing woman, she dealt with all of this crap and, never sought help. What, she's a saint. But that's not true. You don't need to. And we are honestly living in 2025 where you don't need to suffer.
Mhm.
And also I will say that we are also living in this generation where, we have social media and there's so much education that's happening, and you just have to know which people to follow. And, because there are some that are really good at explaining things and symptoms that, you can learn a lot from. I will say that I'm Pakistani and I went to Pakistan about last year. And I felt really sad because, the women there, so I talked to my cousin who's a gynecologist and I said, what do you offer women for that are going through perimenopause and menopause? And she said, nothing. We don't have medications for that. And
Mhm.
I felt really sad because I was like, gosh, like here we are in the US and we take so many things for granted, I feel. Um,
Mhm.
and, we have access to medication, right? We have access to medication if we want it. Nobody's saying you have to have it, but if you want it and if you understand the benefits of it and how it's going to affect your life and longevity and it prevents chronic disease, how it prevents osteoporosis and things like that, then you may want to consider it, right? And then I thought about the women over there that don't have access to it. And just it really didn't feel fair, right? Or that they don't even have the knowledge for it, or they don't have access to the education. And I just wish more women had access to the education. So that's part of my goal for my podcast.
Right. Well, I'm so appreciative of you for your podcast and for you joining us today. One of the things that you and I were talking about before we started was that there are even physicians and myself, I'll throw myself out there too, to say that I am not as up to date with this as I know I could be. There's lots of new training that's out there, and lots of changes that are being made to guidelines. And my sincere hope is that I myself and other physicians will really take heed to some of these things that you and I have discussed today and that you've brought up here, because we want to be doing what's best by our patients as well, right?
Absolutely.
We want to not hear our female patients go through these litany of symptoms and think, okay, well, I don't know what to do about that. Or even worse, to think, well, I don't want to do hormone replacement therapy for you because of what I learned in my training 20, 30, 40 years ago, which is
Exactly.
not the standard of care anymore. And so I really appreciate having you here today. It has certainly sparked in me a desire to continue to learn more about the treatments that are available. But I hope in my listeners that it's encouraged them to start having these discussions with their primary care physicians, to have these discussions with their gynecologist. And if you get to a space where you're stuck and you're having these symptoms and you're just not getting the care that you need, it is to continue to push to advocate for yourself, because we have heard Dr. Lodi today. We know that there are docs who are out there who are practicing medicine in a way that can help you get past these symptoms that you're having. Dr. Lodi, I'm going to give you last word here. Any other thoughts from you? This has been rich. I appreciate you so much.
Yeah. So, I think that the one thing, if I could tell your listeners, is that even if they decide never to go on hormones ever, right? Like they're just like, you know what? I'm scared of it. I don't care what anyone says. I don't care. I'm never going to go on it. Vaginal estrogen, we know, is a local estrogen. It is absorbed through the vagina. It's kind of like a cream. You can use vaginal estrogen cream. It's like a moisturizer for your face, but it's, in the vagina. And actually, some people are even using it on their face because they say
I
it's
did not know that part.
yes, yes, they're using the vaginal cream on their face. But so there are, I would say to use vaginal estrogen cream, and I'll tell you why. Brittany, if there was one medication that I wish I could give to everyone in the world, the vaginal estrogen, because with hormonal therapy, menopausal hormonal therapy, the one that is systemic, meaning the one that goes throughout the whole body, there's definitely nuance to it, and it is some people are not candidates. Most women are, but some women are not. So you really need somebody that understands that. However, with vaginal estrogen, there are very few, if any, contraindications. The only one that I've ever heard of is leiomyosarcoma, a history of that. But I will tell you that it is very, very safe. It's local. It doesn't, go throughout the whole body. It's just for that. And if that vaginal estrogen, it really, I mean, I say that it saves lives, but it also saves marriages. It's more about your bladder health. It's about preventing recurrent UTIs. It's about increasing that lubrication. It's about maintaining that anatomy. It's about maintaining that pH of the vagina so you don't have recurrent bacterial vaginosis, so you don't have this, recurrent yeast infection. It's for all of those reasons that I would ask your patients to really think and consider vaginal estrogen, because it really does save lives, but it also saves marriages and relationships.
I love that. In the last maybe week or so, I've found myself reading a lot more articles about vaginal estrogen and a
Yeah.
lot more information. about just the prevention of the recurrent UTIs and other symptoms that you mentioned. So definitely along those lines of truly being able to save lives, but to your point, to save marriages as well. And so it is certainly, even before this, our discussion together, but even more now, is something that I'm really going to work to incorporate into my practice. So thank you again so much. I have enjoyed having you here today. Again, your socials, I'm going to link your Instagram, your TikTok, but also your podcast. And tell us again your podcast name.
Yeah, the Muslim Sex Podcast. It's
I love
available
it.
everywhere on YouTube, on Spotify, and Apple, everywhere.
I love it. And so, to my listeners, I really do encourage you to go check out Dr. Lodi on her socials, but also on her podcast, because I know that she is dropping equally as awesome information on her own podcast as she has with us here today. Dr. Lodi, thank you so much for your time. I wish you all the best in everything you do. Thank you.
Thank you. Thank you for having me come on. Thanks.
Hey, thanks for listening in today. I hope something you heard in this episode will help you on your journey to becoming healthier. Remember, this podcast offers general health information. I am not your personal physician. If you need advice that is specific to you, be sure to consult your physician. If you enjoy this podcast, please consider sharing it with a friend and reviewing it on Apple Podcasts. Also, be sure to subscribe to the show so you never miss an episode. Tune in next week for another great episode of Headed to Healthier. Until then, take care of yourself. Talk soon. Bye.